We're fortunate to have with us today Professor Harold Pollack from University of Chicago, the School of Social Service Administration. And Dr. Pollack is a real expert in integrating public policy and health and public health, and works on a variety of issues. And he's going to speak not only on patients, but I think a little bit on government perspective as well. Dr. Pollack.
Thanks so much. I must say, as the last speaker, I sort of feel if you need to stand up and do some Tai Chi or something like that, please feel free to do that. And thanks very much for having me. I really learned a lot today. I must say that there's so many things that struck me as I was thinking about what to key on in the conversation. I think that in many ways, David Meltzer's comment about the need to shift from thinking about specific medical care transactions to a continuing relationship of care is kind of the fundamental challenge that no one quite knows how to solve. I am struck. I spend a lot of my life, I'm the guardian of someone who's intellectually disabled who actually has something called Fragile X syndrome, and I very much related to the issues of genetic testing, and that's a relatively simple disorder which none of the medical providers actually understand that we deal with. It's striking how different the medical system looks when you're navigating the system from the bottom for an individual compared to the way it looks from other vantage points. And we spend $2.8 trillion on healthcare, and we struggle to treat people with basic dignity in the system. And it's really something to see every day. I'll give you an analogy. Some of you may recognize this map. So if you ask any expert on the Middle East, what is it going to look like in 2031? People say, well, there's sort of, if I can get the laser guy to work here. I'm probably zapping myself. There's a little star in the middle that's going to kind of be divided in half. There's two little gray areas. They need to kind of be connected. The people can give you a pretty detailed vision. What's it going to look like in 2031? They say, if it doesn't blow up, this is what it's going to look like. And then you say, okay, well, what's it going to look like 2 years from now? And people say, oh, I have no idea. How are we going to get there? Oh, I have no idea. And I think the healthcare system is a little bit like that. If you say, what is it going to look like in 2031? I think we actually have a pretty good idea of some of the big features of it, at least from a public policy point of view. I think fee-for-service medicine will be dramatically curtailed compared to what it is now. I think on all sides of the ideological debate, people recognize that that is a pathological set of incentives that needs to be pared back. So accountable care organizations, bundled payment, a series of innovations of that sort will, in some fashion, take hold. Low-income people will be on Medicaid or some version of that. There'll be some fraction of people who will not be eligible for Medicaid who will go to federally qualified health centers and clinics and things like that. There'll be something where people can buy subsidized health insurance if they're not quite poor enough for Medicaid, and it'll look a little bit like the health insurance exchanges that will exist soon under the Affordable Care Act. And we can describe pretty much what that system is going to eventually look like if it doesn't blow up. And then if you say, how are we going to actually get to that point? A lot of people say, well, that I have no idea. And it's really quite striking. So let me say a few things about the Affordable Care Act. It's 2,000 pages. It's actually, they cheated a bit. It's got very wide margins and large print and stuff. The really long part of the Affordable Care Act is not the act itself, which is actually shorter than Sarah Palin's autobiography in terms of the word count, but it's the Babylonian Talmud that has to be written to go along with it, which will be many times the size of that. So here's when people here's the. I would say it was from the cheap seats taking this picture, but that would imply that I was sitting down, and I was actually sitting up, jammed in the back, using, as best I could get my BlackBerry to do, a telephoto lens. There's the signing of this thing 3 years ago now. And what did it accomplish? Let me start with just the skeletal facts about it, because that hasn't really come up today. One is that it will eventually cover about 32 million people who would otherwise go uninsured. It establishes at least the principle of near universal coverage for people. It curbs discrimination against people with high expected health care costs. And it does a lot, although we don't exactly know how much and in what way, to ensure that health insurance will actually work when people need it. I actually been doing some work on kids with pediatric cancer for Ronald McDonald House, and I was going around to the United States and to Canada talking to parents whose kids had brain tumors and related things. And every one of the American families was basically heading into bankruptcy or in really serious financial trouble. And the Canadians that I talked to, who were getting the same therapies, by the way, they were at hospital for sick kids in Toronto. They weren't in some movie image of the British National Health Service circa 1950. They were saying, thank God we're not American, because we talk to all these Americans whose kids have the same problems. And hopefully health reform will help with that. And of course, it's also an enormous financial transfer down the income scale, about $196 billion a year. In terms of progressive public policy, this is where the ideological debate is really so stark, because if you took food stamps and the earned income tax credit and public housing and a bunch of things and you added them up, they would be smaller in magnitude altogether than what health reform will do in terms of the transfer, implicit or explicit, of resources to low-income Americans through the vehicle of health care. And of course, it also requires people who can afford it to obtain coverage. From a public health perspective, it's really striking how important the Affordable Care Act is. I think in many ways the Affordable Care Act will be very difficult to implement properly, and it will have many unintended consequences for people at the very bottom of American society who need the most help. This is probably the most important public health policy passed in the past 30 or 40 years. It's certainly a more important AIDS policy, for example, than our national AIDS policy, a more important substance abuse policy than our national drug strategy. And it is a remarkable achievement. It's worth taking a moment to note that, especially in a society that, A, shows such a tenuous commitment to people at the bottom of society. Many of the patients that I'm concerned with are people who really need the most help. And also in a society whose political system and political economy of healthcare are just so screwed up that it's amazing we got any kind of legislation passed at all. So what is it that's so important about health reform from this bottom of the income spectrum public health perspective? So, one of the questions that I'm often asked by people is, how poor do you have to be to qualify for Medicaid? And the answer in 41 states in the United States as of today is, well, you could have zero earnings and you don't qualify for Medicaid. So the people that I work with, so let's consider somebody who's a substance abuser, or maybe it's a homeless person, or someone who's just very poor. And maybe anyone ever go in front of a restaurant in a big city and someone asks you for money? Have you had that experience? And you might think, well, this person may have a mental health problem or a substance abuse problem. Someone should take care of that person. Well, if that person is not a mom and he's not a vet and he has no qualifying health condition, he's probably not eligible for Medicaid. And so if you say, how do we pay for that person's care? They sort of show up at David Meltzer's door, and we sort of try to figure it out, but it's a mess. Well, under the Affordable Care Act, if that person's income falls below about $15,000 a year, they become eligible for Medicaid. And Medicaid has to cover a package of substance abuse treatment and mental health services that actually matches what, a reasonable sense of what that person needs. And that's important for that individual, but it's also important to finance the ecosystem of care in that safety net. So I think it's, from the point of view of the safety net and also from city and county governments that are paying for these things, it's a critical issue. Now, will states actually take up this Medicaid expansion? Yeah, they will. We're sitting here in Arizona, so we know the delicate politics of the Medicaid expansion here. And when Medicaid was established in 1965, it took about 7 years, except for in Arizona, which took until 1982. But Arizona was kind of a special case because of the Indian Health Service. But eventually states will all come in. It may be after President Obama leaves. And why will states do this? Well, it's quite simple. There's just too much money on the table for states not to come into the Medicaid system. There's about a 19-to-1 federal-state match over time, and no state government can turn that away for any extended period of time. The black part in this slide, this slide is for those of you who have eye problems, this is for you. The black part is what the federal government pays, and the little sliver on top is what the state governments pay between now and 2019. Okay. Now, so what are some challenges? So I think there's a couple of challenges we have to mention. One is that without a doubt, health reform as it's implemented will be incredibly screwed up. I think that is, I can make that prediction with 100% confidence. If there were no economic issues and there was no political polarization, this would be one of the most difficult changes in American public policy that we've ever tried to do. And it's occurring in a context where everything is going against us in terms of the ability to work together within our government system. I'll say some things in particular about Medicaid because that happens to be what I know about. The Affordable Care Act is so big and so complex, I can't claim expertise on everything, although I hope in the questions we talk about other issues. There's a lot of panic about the cost of Medicaid. One of the ironies of it is actually look at projections for healthcare costs all the way out. The right end is about 2050. It gets a little uncertain after 2050. I sort of find these long-term projections a little comical because they're so, it's so speculative. Everything that's done for low-income people under Obamacare, Medicaid and the new health insurance exchanges and everything else is actually pretty small potatoes compared to what's happening with Medicare. I mean, that is really the ballgame in terms of what's happening on the public ledger side of health care. And the reason is very simple. The people the low-income, basically healthy poor people just don't cost a lot per person to cover. And so if you look at, let me just see if I can, here we go. So a lot of the people we're bringing into the system are children and adults who are basically healthy and don't cost that much. The real money in Medicaid is coming into the aged and the blind and the disabled and so on. And in fact, in general, in the American healthcare system, the real money is not in people like most of us in this room who are basically pretty healthy. It's in really sick people. And David mentioned the innovation grant that he's working on with people with chronic illnesses who need case management and so on. If we're going to control healthcare costs in Medicaid and Medicare anywhere, we have to somehow deal with the really high-cost patients because that's where the money is. And we really don't know how to do that very well. Now the problem we have with Medicaid is, so to some extent, the panic that you hear in the political discourse about Medicaid is misplaced. We do have to make sure that there is not an undue burden placed on state governments. The wrong level of government is paying for Medicaid is the real economic problem with Medicaid. And actually, I think it's kind of useful that there is that there's this real tension between governors and the federal government about Medicaid because it will keep the federal government more honest about not shifting costs onto the states, which states really can't bear. I think if you look at the history of state government, people sometimes refer to state governments as laboratories of democracy. Sort of the major result of that experiment is states do a really bad job, and health policy is kind of the major result of that experiment. It'd be, there's a reason why the elderly are a powerful group, and we do their health care financed through the federal government because that's the way that you really ensure that things are done properly. Also, the fact that both parties face this fundamental problem with Obamacare, which is the name Obamacare, that it's the centerpiece of the Obama presidency, and that puts both sides in a very difficult position. When I think about Governor Brewer and the dilemma that she faces politically in making this work, how do you make something work that's the centerpiece of your ideological opposition presidency for the next 4 years? That's a real challenge. And so both sides need some help from the other, and how do we do this in a dignified and effective way, given the politics of where we are right now? I should say one of the major issues that no one is dealing with properly, this is an actual cartoon from the New Yorker, it says, is there a doctor who accepts Medicaid in the house? I think my single most disappointing thing in the Affordable Care Act is we really haven't dealt with the fact that we just don't pay doctors enough to take care of poor people. When I try to get my brother-in-law health care, he can't get health care from a lot of providers because they don't take Medicaid, and those providers aren't always very polite or nice to us, but they're responding to the incentives that the state of Illinois has created. And I can yell at the doctor, or I can say, why is public policy creating a situation where so many physicians cannot sustainably treat this population? Let me say a few things about the imperative of cost control. It really is striking, if you look at the federal deficit, how much of it is health care looking forward. And specifically, people often refer to entitlements, Social Security, Medicare, and Medicaid. It's really, as I said, Medicare, and it's just the general cost of health care. If you look at the average cost of a health insurance policy for a family of 4 in the United States, the average cost is something around $1,400 a month. And this picks up of your presentation. We all are payers, and we pay it sometimes in the form of lower wages. We pay it in the form of taxes. We pay it in a variety of ways. But for a very large number of Americans, they just cannot pay this without a financial subsidy. This is $1,400 a month. If is roughly $7 an hour for a full-time worker. And if you're that housekeeper, can you really afford to pay that? In fact, a lot of the people who take care of the intellectually disabled population, such as my brother-in-law, a lot of those people are uninsured because they just can't afford it. If you look at what's happening over time in the federal budget to healthcare costs, sort of in this day of sequester, what's really striking is, it's pretty frightening when you start projecting out into the future. And Medicare and Medicaid, and within that, Medicare is really what's driving the imbalance between tax revenues and expenditures. So in health reform, there are many things done to try to control costs. And there was a very difficult political fight over each of these things. It was nominally an ideological fight, but it was really an interest group politics fight to a great degree. And so we get done with that big fight, and we have a new graph. And this is what healthcare spending is projected to be afterwards. So here's before, here's after. Did you see the difference? I didn't either. We have a lot of work to do in controlling healthcare costs. And my real fear is that in the absence of political consensus to do that, and the absence of political consensus to raise taxes to pay for the programs that we seem to want, that we will cannibalize the bottom part of this chart, which is everything else the government does, which ironically includes things like NIH and the Park Service and schools and all the things that we need to do, and public health, by the way. It's ironic that if you look at money that's going out for lung cancer research, it's done pretty well, but if you look at money that's gone out for smoking cessation, those tend to be cut because of the budget politics. Now, we may be getting a little bit lucky. It is striking how in the past couple of years, healthcare spending seems to have slowed down, and no one really knows how much of this is due to the recession and how much of this is due to other factors. So if you look at Medicare cost growth as predicted by the Congressional Budget Office, it has actually gone down. So that sort of dark orange line refers to the CBO's projections as they made this month. And the line that's a little bit above it is August 2012. And here's Medicaid. And now if in fact these projections are borne out and healthcare costs are slowing down, this will be terrific. I think to count on that seems to be a little bit insane because no one quite knows why it might be slowing down or how temporary that is. Now, one thing that's striking is cross-national comparisons. It is striking how very poorly the American healthcare system stacks up on so many different dimensions when you consider how much we spend. We certainly have excellence in particular areas in our healthcare, but if you look at where we rank, say, versus Canada, we really rank quite poorly when you consider how much more money we spend than they do, both on population health outcomes and on various quality indicators like how many diabetics have a limb amputated and things like that. As a health system, we have fantastic medical technology, but as a healthcare system, our policies have really put us in a very poor place. And particularly since 1980, we've really diverged from other countries in healthcare costs. It's actually striking. If you look in the 1970s, we would not have looked like such an outlier on cost as we do right now. I'm going to skip. I'll mention a few dilemmas, and then I'll close out. One dilemma we have to consider in policy is how much patient cost sharing should we allow? We could definitely curb some inefficient use by imposing greater cost sharing on patients for things like unnecessary emergency department use. The health services research literature suggests that patients will definitely respond to those economic incentives. Patients are also terrible at understanding what's actually valuable health care and what's not. So if you look at the services that are very sensitive to price, you see things like mental health care and things where sometimes people are reducing inessential use and sometimes essential use. Another issue we have is, should we try to do cost control by regulating prices, or should we try to do cost control by regulating the overuse and the volume of care? And if I said the Dartmouth Atlas, how many people here would know what I'm talking about? So about half. So there's wonderful maps that the Dartmouth Atlas has produced, Wenberg and others, that show tremendous practice variation across the United States in hip replacement, lots of services, with really very limited correlations with health outcomes. And there are just places that are more aggressive than other places. And Atul Gawande had a terrific profile of McAllen, Texas, which seems to, where physician culture seems to be, do the most aggressive medical care that can be justified. So they're not harming their patients, but they're spending a ton of money being very aggressive with no apparent benefit to their patients of that incremental spending. Now, and there's certainly things we can do in policy to try to address those kinds of overuse issues. But then there's also, what do we do about prices? Anybody seen the latest issue of Time magazine? There's a 26,000-word essay by Stephen Brill where he goes through medical bills and how high the prices are in the United States. And there's no question that if we really want to reduce medical care expenditures and policy, the easiest way to do that in some ways is to clamp down on prices. It's also the thing that we do that will bring the most unintended consequences. And I mentioned how hard it is for us on Medicaid to get some of the services we need. You can imagine if the whole system did that, at some point we would squeeze too hard, and the overall population would face the same issues. So there's really no easy path that anyone's found economically, politically, or clinically to cost control. And let me say that one reason why that's so hard is there's no one who really is enthusiastic about cost control. Both the supply side and the demand side of the medical economy generally want more stuff. And we often blame insurers. I think during the health reform debate, those of us on the pro-health reform side tended to identify insurance companies as the bad guys. And this was probably smart politically because insurers basically poll with Bernie Madoff as far as their overall political popularity. If Aetna is, if David Meltzer or any of the other physicians talking today say, I want to give this patient a procedure, and Aetna says we don't want to pay for it, you can guess which side the public is going to side. But insurers are really not the problem. If they were the problem, we would have just steamrolled them and we would have been done. And the real problem is the entire supply side of the medical economy has a big stake in being paid. And the entire demand side of the medical economy has a big stake in getting services that people value. And the idea that we have to somehow control costs in some overall way is very difficult to make happen in policy. And so the political economy of healthcare goes very deep. Now, why can't we do better? Now some people say, I guess I would say my fundamental point to close out on is, it's not a lack of knowledge or a lack of health services research expertise that prevents us from getting better healthcare policy. Every wealthy society faces all the challenges that we talked about today. Those are endemic in England, Germany, Switzerland, France, Japan, Singapore, every place. And we seem to be doing uniquely badly in dealing with a lot of those issues. And it's really the fragmented nature of our political structures that's the fundamental issue, not our lack of knowledge, in any particular domain. And some people think it's his fault that we didn't do better, or her fault. Some people think it's their fault. If we just had, if liberals could just win all the political fights, we'd be done. Some people think it's his fault. Or his fault, or maybe his fault for pushing Obamacare. But it's really his fault. And who's this guy? That's James Madison. And, we really have set up a system that makes it impossible for us to make intelligent, evidence-based policies in a centralized way. The most important sentence spoken when President Obama began health reform is, if you like what you have now, you can keep it. And the idea that whatever you do, you have to barnacle on top of the things that people already have, whatever change you want to put in. That's the only way you're going to get any kind of change in the American healthcare system. And it has to happen at a particular narrow time window when the sun and moon lines up exactly right so that you can get a major policy reform. And so we had 1932 was one moment, 1964 was another moment, 2009 was another moment. And the other 95 years of the past century, you couldn't do anything of that scale. And it's really, we're put in a situation where we face the necessity, the difficulty, and the ultimate frustration of having to do these very incremental reforms to deal with very fundamental problems. And and I must say, what makes me discouraged is that we're led into something which has to be, in order to pass, has to be extremely complicated. It ends up being ideologically moderate, but it ends up being organizationally kind of radical if you think about health insurance exchanges and the rest. And really hard to explain. If you said single payer, is it good or bad? We might disagree in this room. It's actually very easy to explain what single payer is. Everybody gets a Medicare card. I could explain to you in a couple paragraphs what the basic policy is. If you say, explain Obamacare, that's a lot more complicated. There's no two-paragraph explanation of it. And that makes it difficult in our politics. And then, of course, I think there's some other people to blame. Let's put this guy on the left as Joe Sixpack. I think the American public does not want to face up to the reality, A, that there are trade-offs that we have to make, and B, that we have to finance the healthcare system that we actually want. So, we just had a 2012 election where it was clear that cutting Medicare was just not a politically feasible thing to do. Okay, so how are we going to pay for that? And it's not the politicians who are the problem here, it's the electorate that has to decide, how are we going to do this? And also the medical profession has to change the way that it does its job. And I think we've already heard from others who know more than I do about some of the challenges that we face in that department. So I'll stop here, and thanks very much.